is also and Dr. Rupam, he will be presenting the webinar. His topic is Diabetes mellitus type 1, Epidemiology and Pathophysiology. So we should go ahead, and with your permission, sir, I'll request Rupam to go ahead. Please,
Thank
Rupam,
you.
take over.
Thank you, sir. Very warm good afternoon to all. Thanks for being a part of this webinar and learning session. So this afternoon we'll be talking about epidemiology and pathophysiology of both type 1 and type 2 diabetes mellitus. So to start with, let us start with the epidemiology of type 1 diabetes mellitus. We all know that type 1 diabetes is found in lesser number as compared to type 2 diabetes mellitus in entire world population. But type 1 diabetic patients, their treatment and clinical outcomes are very crucial. So we'll have to know about type 1 diabetics patients and how to diagnose them, and then go with the treatment procedures. So today we'll be learning about the epidemiology and pathophysiology of type 2 diabetes, type 1 and type 2 diabetes mellitus. So type 1 diabetes accounts for about 5 to 10% of all patients with diabetes and causes more than 85% of all diabetes cases in the age group worldwide. However, Europe has the highest number of children and adolescents from age group of 0 to 19 years with type 1 diabetes mellitus, amounting to 297,000 type 1 diabetic patients. India, however, India and China have low incidences as compared to Europe. That might be probably because a lot of type 1 diabetic patients are misdiagnosed as type 2 and are all the diagnostic modalities in India are not at par. That's why probably our incidences are low. But then to be statistically speculated, it is like 0.6 out of 1 lakh population, and it accounts for a high proportion of the world's children with type 1 diabetes because of their large population. Type 1 diabetes can present at any age. It is believed that type 1 diabetes only occurs in children, but it can present it at any age. We'll be looking at the pathophysiology in future slides. With the highest incidence observed in children age 10 to 14. So incidences are very high in between this age group 10 to 14, but it can also be seen in age groups more than 20 years of age. There's a slight male predominance, particularly after puberty. So
Rupam.
Sir.
Please, previous slide. Previous one.
Yes, sir.
The first point here, this 5 to 10%, this is for the age group of 0 to 14 years?
No, sir. This is for entire type 1
because
diabetes. Because
they mention all diabetes cases in this age group. Now, which is that age group?
Which one? The third point we are talking about, sir?
In the first point.
Type 1 diabetes accounts for about 5 to 10% of all patients with diabetes. This is, sir, if you account type 1 diabetes, GDM, and type 2 diabetes, amongst that 5 to 10% will be type 1 diabetics. Of all the types of diabetes,
okay,
5 to 10% are type 1.
Okay, and it causes more than 85% of all diabetes cases in this age group.
More than 85% of all diabetes cases in this age group worldwide. So
which is that age group?
Correct. Oh, sir, you are correct. That age group is this adolescent age group, which is like 10 to 14 years.
Adolescent. Okay.
Yes. Yeah. Should I move ahead? Yeah.
Ahead, please go ahead.
Yeah. This is the world map depicting the type 1 diabetes in young. This is IDF, International Diabetes Federation Atlas 9th edition 2019. Here clearly we can see that in India, the incidence of type 1 diabetes is less than 5 out of 1 lakh population per annum. Europe, however, has highest prevalence of type 1 diabetes in children. The incidence is increasing by 3.4% per year. 50% of patients diagnosed before age group of age of 20, and another 50% they are diagnosed after age of 20 years. Often mistaken for type 2 diabetes, may make up 10 to 30% of individuals diagnosed with type 2 diabetes. So as I have mentioned, many times this type 2 diabetic patient who are young, at an age group of 20 to 35 up to 40, they're misdiagnosed to have type 2 diabetes mellitus, because diagnosing type 1 diabetes, we need to have some autoantibody testings and at least a C-peptide or insulin assay to clearly document that the insulin production in that patient is almost nil. So then only we can diagnose the patient to have type 1 diabetes mellitus. But in clinical scenario, what happens in many patients who actually have type 1 diabetes, or also there is a type called 1.5, so LADA. So those kind of patients were misdiagnosed as type 2 diabetes as well. Oral agents are ineffective in type 1 diabetes mellitus. We only need insulin therapy because these patients have absolute insulin deficiency. Autoimmune processes are slower and possibly different in those kind of patients, and it is confirmed by islet cell antibodies, as I have mentioned. This is ICA, or we can do a GAD autoantibody, which stands for glutamic acid decarboxylase antibodies. We can check for insulin antibodies, known as IAA, or insulinoma 2 associated antibodies. So very frequently in clinical setup, we do GAD antibodies along with a C-peptide level to diagnose type 1 diabetes mellitus in our patients. Talking about the etiopathogenesis, it starts like beta cell autoimmunity. Environmental challenges are there, which contributes to beta cell destruction. And of course, we have genetic predisposition for this condition. It is very less common than type 2 diabetes mellitus, as we have seen 5 to 10% only amounts to type 1 diabetes. Rest are type 2 diabetes and other types of diabetes that we see in our clinical setup. Etiologies, there are 3 theories. Although the pathophysiology and etiology of type 1 diabetes is still not clear, but these theories are like viral infection in early phase of life, like mumps, rubella, CMV, mono infections, and it may lead to destruction of beta cells. There are also genetic predispositions like HLA-DR3 and 4 genotype and HLA-DQ point mutations, which also contributes and can make a patient type 1 diabetes to suffer from type 1 diabetes. And of course, we have autoimmune inflammation that leads to islet cell antibodies, and that antibodies itself kills the beta cells, and then we have absolute insulin deficiency. In pathogenesis, marked absolute insulin deficiency resulting from diminished beta cell mass, a low serum insulin level will be there, and at diagnosis many a times we find ketoacidosis in those patients, because the result of absolute insulin deficiency would lead to ketoacidosis, and then patient will end up in ICU setup, and then only they get diagnosed with type 1 diabetes mellitus. Moving ahead with the pathophysiology, type 1 diabetes beta cell destruction usually leading to absolute insulin deficiency. 2 etiopathogenesis are postulated: immune-mediated diabetes and idiopathic diabetes. So let us look at immune-mediated diabetes. It commonly occurs in children and adolescents, but it can occur at any age, as we have seen. Autoimmune destruction of beta cell has multiple genetic predispositions and environmental factors that are still poorly defined. So we still definitely don't know the absolute cause of type 1 diabetes mellitus yet. Although patients are really obese, the presence of obesity is not incompatible with the diagnosis. Also prone to other autoimmune disorders such as Graves' disease, Hashimoto's thyroiditis, celiac sprue, autoimmune hepatitis, myasthenia gravis, and pernicious anemia that happens because of B12 deficiency. So those type 1 diabetic patients, they are also prone for a lot of other autoimmune disorders because of presence of all those kind of antibodies in their blood. The rate of beta cell destruction is quite variable. Some patients may deteriorate very fast. Some may, have a honeymoon period kind of thing where the insulin secretion increases in due course of time. Then patient has remission, and again he'll end up in ketosis state. So every patient is different, and then the destruction of beta cell is also variable. Being rapid in infants and children. In children and infants, this beta cell destruction happens very fast, and they'll end up in critical condition too fast. Some patients may present with ketoacidosis as the first manifestation of the disease. Others have modest fasting plasma glucose that can rapidly change to severe hyperglycemia or ketoacidosis in presence of infection or other stress. What happens is, if a patient's beta cell destruction starts, and then on top of that, the patient gets some kind of infection, whether it is viral or bacterial, the entire beta cell destruction it accelerates, and patient suddenly lands up in severe hyperglycemia, glucotoxicity, and lands up in ketoacidosis. Still, others, particularly adults, may retain residual beta cell function sufficient to prevent ketoacidosis. So, in adults, usually what happens, somebody who is 20 plus or 25 plus, some beta cell reserve is there, which prevents ketoacidosis, but then hyperglycemia is evident, and it is quite high, 500 plus, but then ketosis does not happen because of residual beta cell. Some amount of insulin is present in those patients to prevent ketoacidosis, but those patients are also type 1 diabetes patients when we assess them for the antibodies, and then when you look at the C-peptide levels in clinical setup. What are the markers of type 1 diabetes mellitus? We have already seen. We can check for islet cell autoantibodies. It can be checked in laboratory. Autoantibodies to insulin, IAA. I have mentioned about GAD autoantibodies, which is found in later phases of also patients. Islet cell autoantibodies, they disappear very early, but then GAD remains in the patient, and you can assess that GAD to diagnose the patient to have type 1 diabetes mellitus. Again, autoantibodies to the tyrosine phosphatase can also be seen in laboratories in those patients. Autoantibodies are present in 85 to 90% of individuals when fasting plasma glucose is detected initially, and also has strong HLA associations with linkage to the DQA, DQB, and DRB genes. So this genetic profiling of the patient also can be done for academic purpose, but in clinical setup, doing a genetic assessment is not necessary to diagnose the patient. So again, these HLA, DQ alleles can be either predisposing to protective. And now talking about idiopathic diabetes. So when we take this word idiopathic in medical science, it essentially means that we actually don't know the cause of the entire disease or condition. So some form of type 1 diabetes have no known etiology. So those are called idiopathic actually. Some of these patients have permanent insulinopenia, that means less insulin in circulating blood, and are prone to ketoacidosis but have no evidence of autoimmunity. In those patients, we might not find any autoantibody, but their insulin levels are very less. So in these cases, we actually don't know the etiology of the condition. Although only a minority of patients type 1 diabetes fall into this category. Very less patients will fall into this category if you really want to assess them biochemically. Individuals with this form of diabetes suffer from episodic ketoacidosis. When insulin secretion goes down, they might exhibit some amount of ketone bodies in their urine and serum. But then again, when beta cells again secretes more insulin, it compensates, and then ketoacidosis disappears. So although very rare, it can happen in our patients. This form of diabetes is strongly inherited, lacks immunological evidence for beta cell autoimmunity, and is not HLA associated. Neither genetic predisposition or autoantibodies are seen in those cases. This is the natural history of pre-type 1 diabetes. We can clearly see here how the beta cell mass eventually decreases with due course of time. We have a putative trigger like the viral infections we are talking about, and then the beta cell goes into insulitis, that means inflammation of beta cells, and because of cellular autoimmunity, the beta cell mass goes down, and then beta cell insufficiency is there, where the patient exhibits some amount of impaired fasting glucose or impaired glucose tolerance, and eventually the patient lands up in fulminant type 1 diabetes mellitus when the beta cell mass is less than 10%. So when less than 10% beta cell mass is there, the patient is very prone to have ketoacidosis, and that's how the patient gets diagnosed most of the time. These are the genetic susceptibility we have mentioned. For academic purpose, we can go through, but then clinically we don't assess all those things. Like the CD4 plus and CD8 T cell and macrophages, we can assess. Two HLA genes, DR4, DQ8 and DR3, DQ2 are present in 90% of type 1 diabetes patients. So we can look for those genes. The genotype combining the two susceptibility haplotypes like DR4, DQ8, DR3, DQ2, it contributes the greatest risk of the disease and is most in children in whom the disease develops very early in life. So these are few things which we can do to connect the patient genetically because of which genes the patient develop type 1 diabetes mellitus, and these are really of academic interest. Again, representation, this is a representation of the process whereby antigen is presented to CD4 cells by HLA class 2 molecule on the APC. So this is how the beta cells are destroyed. The four major genes associated with type 1 diabetes, CTLA4 is an inhibitor of T cell activation as it lymphoid tyrosine phosphatase, also known as LYP, which is encoded by the genes. So basically, this is the mechanism how our own body attacks the beta cells, and hence the beta cells are destroyed and patient lands up in severe hyperglycemia and ketosis. This is interesting how different cells attack the islet of Langerhans in pancreas. So beta cell undergoes apoptosis with triggers of genetic predisposition like HLA alleles and environmental factors like infections we talked about. Local inflammation with immune cells in the pancreas, secretion of inflammatory cytokines, and which lead to beta cell apoptosis in patients. The pancreas then they perform their cytotoxic activities leading to beta cell destruction and type 1 diabetes mellitus. Genetic and environmental interactions. Increase in type 1 diabetes has been accompanied by concomitant widening in HLA risk profile, which suggests increased environmental pressure on susceptible genotypes. The most popular candidate are viruses like enteroviruses, rotaviruses, rubella being suspects. The strongest data we have is with rubella virus. In early phase of a patient's life, if they get rubella, the chances of developing autoimmunity and then destruction of beta cell is very high. So infants infected with congenital rubella syndrome are said to be at increased risk of type 1 diabetes mellitus. Also, some enteroviruses like Coxsackie B virus are less prevalent in countries with high incidence of type 1 diabetes mellitus. Type 1 diabetes is believed to result from a complex interplay between genetic predisposition, immune system, and environmental factor. Enteroviruses, particularly Coxsackie virus B4, are perhaps the most well-studied environmental factor in relation to type 1 diabetes. Higher rate of enterovirus infections defined by detection of enterovirus, IgM and IgG, or both viral RNA which can be done by RT-PCR, and viral capsid protein have been found in patients with diabetes at diagnosis. Temporal relation between infection and autoimmunity is there, and persistent enterovirus infections and also common amongst type 1 diabetic patients. These are again genetic risk like HLA alleles, GQB1, DQB1, other variant 0302. So these are also related with type 1 diabetes. So how do you know in general in clinical setup who has the highest risk or greatest risk of developing type 1 diabetes mellitus. The three principal autoantigens identified were GAD65, insulin autoantibody, and IA2. 90% of people with newly diagnosed type 1 diabetes have autoantibodies to at least one of these three antigens. So to diagnose type 1 diabetes, we need to do autoantibody test when we go by textbook. Amongst these, IA2 and insulin antibody and GAD is most commonly done in clinical setup. Insulin autoantibodies are more prevalent in young children. IA2 antibodies often decrease after diagnosis, and antibodies to GAD tends to persist. So even if we want to do someone already diagnosed as type 1 diabetes, if we want to do after 2-3 years, we want to confirm the diagnosis, we need to do GAD, not IA2, because IA2 will disappear. It is in the pre-diabetes phase that eyelid autoantibodies have been most useful. They appear to be already present in most cases of future diabetes by the age of 5 years. This indicates that the autoimmune process smolders subclinically for many years in the majority of patients, and that clinical symptoms do not appear until up to beta cell to be destructed to have clinical symptoms in these patients. Eyelid cell autoantibodies predict autoimmune diabetes in first degree relative. That the presence of 2 or more autoantibodies in people in the general population is highly predictive of future disease, and people who have IA2 antibodies are at very high risk. A series of virus candidates like picornavirus, rotavirus, herpes, mumps, rubella, and retroviruses, as we have already discussed, and nutritional factors were suggested to induce immunopathological processes. Antibodies to milk protein. So also milk. It is also, there are a lot of papers that suggested that in early age, if a child gets cow milk, in those cases also the production of antibodies against beta cell has been seen. So it is not advisable to give cow's milk or any other milk other than the mother's milk to young children nowadays. Again, T cell responses to these proteins were reported to be increased among children with type 1 diabetes mellitus. This is again timeline for type 1 diabetes. We are not going into detail. So this depicts that how the insulin production decreases, and it is not a linear line, but that a zigzag line. Sometimes what happens, the insulin production increases, again it decreases, again patient may have a fertile field, as it is called, that insulin, the beta cell starts secreting more insulin, but eventually it goes down and a patient lands up in severe hyperglycemia. This is a schematic representation how type 1 diabetes occurs. So this is a summary of what we have learned is all those slides. So look at the line, the orange line, how the beta cell mass decreases and insulin secretion decreases stage by stage in our diabetic patients. At last, about type 1 diabetes, let us discuss what potential target for therapeutic interventions we have in type 1 diabetes mellitus. We all know that in type 1 diabetes, oral drug will not work. We need to give basal bolus insulin therapy in those patients, and it's pretty difficult because most of our patients are very young, like 3 years, 5 years. So giving them insulin shots, like 3 to 4 shots a day, it's a very cumbersome job, not only for doctors, not only for physicians, but also for parents. So a lot of research are going on in type 1 diabetes. So what are those things which are in pipeline is genetic susceptibility, environmental factor we have seen that leads to beta cell destruction. And first we have appearance of eyelid autoantibodies, diagnosis of type 1 diabetes, less than 20% of beta cell remaining, then we have type 1 diabetes appearance. So the modalities are like beta cell regeneration. So what we have to do is we'll have to try to regenerate the beta cells to save those patients from complications, and for euglycemia, definitely we need something that secretes insulin endogenously in the body. If we have to avoid those basal bolus exogenous insulin shots, or else we will have to try to renew the source of islets. So how we do it? We can do eyelid transplantation, which there are a lot of trials which are going on, where they have tried to transplant the eyelid cells, eyelid of Langerhans, and hence replenishing the beta cells, which will eventually increase the insulin secretion, and gene therapy to generate super islets. So there are some genetic trials going on to remodulate the beta cells, and which can save those patients by more insulin secretion. So that was all about type 1 diabetes. Let us talk about other 90% of our patients. The most common type of diabetes is diabetes mellitus type 2. This is actually the real pandemic we are going through. In 2019, Southeast Asia, 88 million people have type 2 diabetes. This is when in India it is said that 49% of our patients don't even know that they have diabetes. And out of those 50% who has got the diagnosis, only 20 to 30% patient has treatment, and out of those 30% patients, only 15% patients are under a good under optimal glycemic control. So Shina, this is actually the real pandemic, because we know the mortality and morbidities that appears because of uncontrolled blood sugars in cardiovascular system and cerebrovascular system, and of course in chronic kidney disease. So the numbers are going to rise. In 2019, it is 88 million, and there it is speculated that around 74% increase will be there by end of 2045, and the number will become 153 million. 1 in 5 adults with diabetes lives in this region, Southeast Asia. 1 in 4 live births are affected by hyperglycemia in pregnancy. So gestational diabetes mellitus is very prevalent nowadays. That's why 1 out of 4 live births, they are already exposed to hyperglycemia in vitro. This is the prevalence and the speculation how much population will get affected with diabetes in near future. Again, talking about IDF 2019, 1 in 11 adults have diabetes. 1 in 5 of the people with diabetes in the world come from Southeast Asia itself. 1 in 6 adults with diabetes in the world come from India. So we are number 2 on paper as far as diabetic prevalence is concerned, but actually we are world's diabetic capital, because the diagnostic modalities are better in China as compared to India. In India, 49 to 50% population are not even diagnosed. So if you count those patients, we are actually number 1. 1 in 2 people with diabetes remain undiagnosed and are at higher risk of developing harmful and costly complications. 1.2 million deaths are attributed to diabetes. 1 in 4 live births are affected by hyperglycemia in pregnancy, and total cost of diabetes treatment in US dollar 8.1 billion. The second lowest regional diabetes related health expenditure. The expenditure because of diabetes related complication is tremendous. So if we have to reduce the cost of treatment, we'll have to prevent the patient to end up in complications. State-wise, more than 10%, we can see entire India is orange, which depicts more than 10% prevalence, and we don't have any data from J&K. As per the ICMR INDIAP 2017 data, prevalence of diabetes in India, we have highest number in urban, amongst urban population. Rural it is lower, but still increasing, and somehow men have more diabetes. Men had more diabetes in 55 to 64 age group, but then it becomes similar when we consider population more than 65 years of age. Current scenario of control in India, IDF estimates that there are 72.9 million people with diabetes in 2017, with almost 35.5 million people in India with diabetes being unaware of their diabetic status. This is the official statement. Amongst diagnosed cases, 70% of cases remain uncontrolled. So the scenario is pretty bad. However, 90% of those uncontrolled diabetic patients assume that their disease is under control. So although it is uncontrolled, the patient will think that my sugars are well under control. I don't need to consult my doctor. Neither I will have to follow the diet and exercise modules that has been prescribed. So to mitigate all those misconceptions amongst the patient, we'll have to work more towards the awareness of not only diabetes but diabetes related complications that those are preventable actually if patient really they're aware of the condition that they might land up if sugars are not under control. Diabetes remains undiagnosed and uncontrolled in patients across many states in India. There is a latest data from last year's. The average HbA1c control in entire diabetic population of India is 8.5. Whereas we have a target of below 7% to prevent complication, but it is looking very difficult to bring all those patients to the optimum glycemic control HbA1c levels. And we Indians are not same as the Western counterpart. At diagnosis, I mean, these are the differences. At diagnosis, age at diagnosis, we become diabetic very early, a decade early as compared to the Western population. Our BMI is low. Mid-arm circumference is 20% lesser, but then look at the waist ratio, hip ratio, it is more as compared to the Western population. Fat percentage is higher, 30% higher in Indian population as compared to the Western counterpart, and we are more insulin resistant as compared to the Western population. So these are the characteristics because of which in the Indian populations are very vulnerable for diabetes and other metabolic conditions. There is one paradox known as the YY paradox, which was, they wanted to look at the visceral adiposity of Indian population and Western population, and two person with same BMIs were assessed, but they found that the BMIs were same, one guy Indian, one guy Western, but the visceral adiposity is much higher in Indian guy as compared to the Western one. So we are known as the thin fat Indian phenotype. We look thin, but we are very fat from inside. That's why all those insulin resistance and early diagnosis of diabetes is there in Indian population as compared to the Westerns. This is beta cell dysfunction, which plays a critical role in Indians. We have greater post-meal hyperglycemia because of the beta cell dysfunction. Rapid progression from pre-diabetes to over-diabetes, that happens in Indians. Rapid oral drug failure because of probably beta cell degradation. It happens very fast. And decline in beta cell function more sharply than insulin sensitivity with age. So these are the characteristics because of which it's very difficult to have optimal glycemic control in Indian population. So what causes type 2 diabetes? We all are almost aware, but then a very important role, apart from the pancreas, very important role is played by liver, because we know liver does all those processes like glycogenolysis, gluconeogenesis, and glycogenesis. Glycogenolysis is conversion of glycogen, which is glycogen is the storage of energy in liver. And when we need energy, glycogen converts into glucose through glycogenolysis. And when we produce new glucose from non-carbohydrate based products like fat and protein, it is called gluconeogenesis. That also happens in liver. And when glucose is converted into glycogen as a storage in liver, this is called glycogenolysis. So what happens in diabetes is, in diabetes the body makes even more glucose because of perceived lack of glucose. When we eat, the carbohydrate converts into glucose and it goes into blood. Although sugars are very high in blood, our peripheral tissues and muscles, the cells does not get enough glucose for ATP production because the carrier in between is insulin. Insulin acts as a carrier from blood to peripheral tissues. So because of lack of insulin, the peripheral tissues does not receive enough glucose, and they send signal to our brain to produce more glucose, whether from glycogen or from non-carbohydrate products. So glycogenolysis increases, gluconeogenesis increases, and glycogenesis decreases. So although we have a lot of sugar in blood, again the liver produces more glucose. So it's a fake signal that peripheral tissues give to our brain, and other hormones comes into play, and the liver secretes more glucose, leading to more hyperglycemia in our patients. This is a pathogenesis. Genes and lifestyle and diet, it leads to insulin resistance. And along with that, if somebody have normal beta cell function, all because of the insulin resistance, because of the normal beta cell function, it compensates the insulinemia. Compensated insulinemia is there, and the patient becomes normoglycemic. But then when you have some amount of beta cell failure along with the insulin resistance, what happens on the right hand side is insulin resistant along with abnormal beta cell function, relative insulin deficiency will be there, and we'll have hyperglycemia and over type 2 diabetes mellitus. So there are two aspects, like a slow degradation of beta cell mass along with insulin resistance. The patient will have evident hyperglycemia and type 2 diabetes mellitus. So what is insulin resistance? It's a major defect in individuals with type 2 diabetes, reduced biological response to insulin, strong predictor of type 2 diabetes, and closely associated with obesity. So what happens is we have receptors called GLUT2, GLUT4, where the insulin acts as the insulin first carries the glucose along, and insulin acts as a key to open the receptors GLUT2 and GLUT4 in peripheral tissues. What happens when you have insulin resistance is all those receptors are actually closed. Insulin cannot open those receptor gates, and the glucose cannot pass inside the cell to produce energy. We know that we need glucose to be used in our Krebs cycle, TCS cycle, to produce ATPs, adenosine triphosphate, which is the unit of energy. But if the cell does not get any glucose, the cell itself becomes fatigued, and that's why clinically we see many patients, they lose a lot of weight initially when they are diagnosed with diabetes. This is actually unhealthy weight loss. They are losing out their lean mass, not fat mass. Again, insulin resistance and beta cell functions are core defect of type 2 diabetes mellitus. So both together will cause type 2 diabetes. Insulin resistance reduced response to circulatory insulin. So what happens is we have higher glucose output from the liver. In muscle, we have lesser glucose intake. In adipose tissue also, glucose uptake is very less. So ultimately in blood itself, we have hyperglycemia. So it's like because of lack of insulin, all those tissues, peripheral tissues, are refusing to take up the sugars that are present in blood. And we have evident hyperglycemia in our blood, which in turn will harm all our organs, and patient lands up in complications. 90% of people with type 2 diabetes are overweight or obese. So obesity itself is a risk for severe insulin resistance. If somebody does not look obese from outside, even those cases, we already learned that Indians have a lot of visceral adiposity. So when we say that you have fatty liver, you have fatty pancreas, almost 70% of our general population will have fatty liver. That itself is a sign of insulin resistance. So this is how obesity leads to insulin resistance, and then we associated with beta cell degradation, and ultimately patient lands up in hyperglycemia and type 2 diabetes mellitus. More than 80% of patient progression to type 2 diabetes are insulin resistance. So as we have learned, type 2 diabetic patient, more than 80% will have signs of insulin resistance, and clinically when we look at those patients, they can have acanthosis nigricans, which is a sign of insulin resistance found in our diabetic patients. Very important slides. Earlier we thought that there are only 2-3 defects of diabetes, but In 2009, Dr. D. Franzo, who is also known as the father of modern diabetes, he postulated this pathogenesis octet, also known as omnious octet. So as you can see here, the pathophysiologists are like decreased insulin secretion, the blue one, we learned about that. Decreased incretin effect. So incretin is, there are gut hormones like GLP-1 and GIP-1, which are secreted from the L and K cells of duodenum, which facilitates beta cell, facilitates insulin secretion from beta cell, and it suppresses the glucagon. So when we have decreased incretin effect in our body, so less amount of GLP-1 and GIP-1s, then the patient can land up into hyperglycemia. Increased lipolysis, we have more lipolysis in peripheral tissues, that also leads to hyperglycemia because it again produces more glucose. Increased glucose reabsorption, what happens in diabetic patients from kidney, we have SGLTs, sodium glucose co-transporter receptors in descending loop of Henle. There what happens is we are supposed to pee out extra glucose normal physiologically, but then in diabetic patient that threshold becomes higher, so that glucose which goes into urine, it comes back to the body, and again hyperglycemia happens. So now to counter that, we have newer therapies like SGLT2 inhibitors, which inhibits these receptors, and then the patient is made to pee out lot of sugars, and it excretes the extra sugars from the body, and the patient attains normoglycemia. Decreased glucose uptake, we have already seen that peripheral tissues, they refuse to uptake the glucose because of the insulin resistance. Neurotransmitter dysfunction, the brain gives wrong signals to the beta cells, and they cannot really judge the amount of glucose and insulin required in the body, and then again the beta cells fail to counter the hyperglycemia. Increased hepatic glucose production, we have already learned increased gluconeogenesis and glycolysis, and by this process it again patient lands up into hyperglycemia. And increased glucagon secretion, we all know that glucagon increases sugar in the body, so this is also a part of pathophysiology of type 2 diabetes mellitus. The last slide, let us learn a little bit about the sign and symptoms, because diabetes is every home's disease right now. Every home has 2 to 3 patients, and so that we can at least know about the symptoms and guide someone if they encounter these symptoms, and then they guide them to check their blood sugars and get optimal treatment. Very common is 3 P's: polyuria, polydipsia, and polyphagia. That is, polyuria is more urine, polydipsia is more thirst, and polyphagia is hunger, increased hunger. Weight loss is also there initially. Why polyphagia? The patient wants to eat more and more. Although his sugars are high, he wants to eat more because the peripheral tissues are not getting enough glucose. It sends signal to brain, as you have learned the neurotransmitter disorders, that the person needs to eat more. So wrong signal, that body tissues send signal that we want glucose. The brain sends signal that we need to eat more, although blood sugars are very high, because it is not reaching to the peripheral tissues. Why polyuria? Because glucose molecule carries 2 molecules of water along. So when glucose is passing through our urine, there will be more water going out of the body. And again, because of that, we have polydipsia, that is increased thirst. So more water going out of the body will be needing to drink more water. These are very common signs. Uncommon are nausea, vomiting, lethargy, fatigue and weakness, hyperventilation in case of ketoacidosis, and HHS. Weight loss is very evident because of less sugar supply to peripheral tissues. The lean mass is lost in most of the patient, and they will have sudden weight loss, around 10 kgs of weight loss in last 6 months. We can suspect that the patient might have diabetes. Blurred vision, sometimes what happens is the wounds are not healing. Some patients will complain that I have tingling sensation over my feet and hands. Those are also uncommon signs, although of diabetes, type 2 diabetes mellitus. So thank you so much for your patient hearing. This is what I have to present today. Thank you.
Thank you, Dr. Rupam, for a wonderful presentation of this webinar. The topic you have selected is very much relevant of today's time and generation both, because this generation is going to take over the older one in time to come, and I hope that they learn a lot. So anyone who has a suggestion or questions to Dr. Rupam are most welcome. Meanwhile, Rupam, I would like to clarify a few things. Is there any role of migration? Suppose there is migratory population, and is there any association or relation between migration and diabetes mellitus? Whether one or two, whatever it is, or is there any literature available? That is one thing.
Migration per se, if we look at the Asian American population, so being Asian itself, we have more chances of having diabetes because of what I have presented here as a slide. We have more chances of insulin resistance. So in those cases, even if I migrate from India to abroad, there also I'll have chances of diabetes, and my offsprings will have more chances of, but it's in our genes. And second aspect is the dietary habits that can be influenced by migrations. So these are the two things I think can influence. Yeah.
And any racial factor?
Yes, of course, sir. There are a lot of studies that different races have different predisposing factors, which can lead to different prevalences in different ethnicities. Again, for instance, Southeast Asian population have more chances of having diabetes. Chinese population, they are also Asian. Diabetes is seen more as compared to Western counterpart. There, the prevalence is less.
And regarding environmental factor, do you think any change in sudden change in environment, say peak of winter, if there is a sudden drop of temperature even in the winter season, because all the time it is not that much pleasant everywhere. So sometimes it is unbearable. So does it exaggerate the level of means blood glucose and lead to diabetes?
I'm not sure, but then, sir, any infection because of, as you have mentioned, winter period, any kind of viral infection, even if it is rhinovirus or adenovirus, common flu, then also any infection in body, sugar should go high. If I have a toothache also, that time also sugar will go high because of the corticosteroids that are secreted to counter the infection. So steroid therapy means hyperglycemia.
And besides this viral infection, because viral pancreatitis, it is a very severe condition, but is there any bacterial pancreatitis or bacteria affecting the pancreas?
The bacteria are uncommon, sir, but then pancreatitis can be caused by anything. I mean, it is itis means inflammation. So most common cause of pancreatitis is alcohol, of course, then trauma, and then comes the bacteria and viruses. But then I would not deny about the bacteria, but I'm not sure which bacteria is most common.
Oh, okay. Then you mentioned that beta cell of Langerhans, they destroy more in children. They are destroyed fast in children.
Correct.
In type 1 diabetes.
Yes, sir. That I also, and this is very interesting question, sir. I tried to find out why, but how I can connect to this is probably because those patients who have already less beta cell mass, they get diagnosed early in 5 years or 6 years. So their beta cell mass is already 30%. So from 30 to 10, it degrades very fast. But in adults, if somebody's beta cells are reserved for 20 years, in those cases, the beta cell death are gradual, I would say. Probably that might be a reason, sir, how I understand.
Okay. So the mass of the pancreas might be playing its own role as the age advances. All right. Then seasonal variation in reporting diabetes cases in hospitals.
Yeah, anyways, in winter patients are coming less. This is for the, I mean, the peak time is summer. This is the time when we encounter more patients, because probably they're comfortable coming out in this one is in summer. But then diabetes is a yeah, this is environmental factor, but then diabetes is a chronic condition, so it does not make any sense. More patient in summer. Of course, infectious diseases are, I mean, more in summertime. But diabetes, it should be similar, but then patients are more comfortable in summer, I think. That's why we have more patients in summer.
What would you suggest for community screening for diabetes type 1?
Type 1, sir, it will be very difficult, because we need to have autoantibody screening and C-peptide levels, the insulin levels. That is difficult, but then we can educate the teachers in school, and we are running some programs, sir. We have associations. The teachers can really make a very important role there, because this ketoacidosis signs, post-mols breathing, the patients, if we I mean, make them learn those, they can really look at the signs and then refer the patient to physicians or medical help. For type 2 diabetes, we have a lot of screening tools.
Yeah. So that's why I'm interested in knowing about type 1 diabetes early screening in the community, because we have been going for a school health checkup. So if it can be of some use to them.
A random blood sugar in screening, sir, a random blood sugar we can do for all children, but then
now RBS, it is very difficult in school.
Children, correct.
Children will not be ready. Now gestational diabetes mellitus, you mentioned in type 2 type of diabetes.
Pardon, sir?
So gestational diabetes, right? In diabetes during pregnancy.
Yes, sir.
So once the delivery occurs, so that lady gets to normal level, blood glucose goes to normal.
Yes, most of the time.
Or is she still have more chances of getting diabetes in time to come, whether she is pregnant or not?
Yes, sir. So what happens is, during pregnancy, because of the placental hormone, sugars are very high, and we had to give insulin therapy only, because other drugs are not approved. And once the placenta is out, the patient becomes normoglycemic. But it does not mean that patient will not become type 2 diabetes. After 6 months or 1 year, we'll definitely have to follow up the patient, because they already have signs of insulin resistance, and these patients become diabetic in due course of time.
And what is your opinion? Was she previously also diabetic which remain undiagnosed? Is there any possibility of that?
Yes, a lot many cases this happens. PCOD, sir, itself, polycystic ovarian disease or syndrome, it's a sign of insulin resistance. So nowadays, more than 50% of ladies, they have this condition, PCOD, some amount, and obesity. And those patients, again, they gain a lot of 10 to 15 kgs of weight during pregnancy, and they eat more, and they become fulminant type 2 diabetic.
Then another query is, in our country, Indian people, they remain more undiagnosed than Chinese. What could be the reason for that?
Well, that is because of the unawareness amongst general population and lack of our medical entire system. We are not. Our medical,
manpower is not there.
Not even manpower. Our entire medical system is not not enough
very
to
much
diagnose
increasing.
such a huge population.
But
So,
now,
and
since government has come out with the special program for non-communicable disease, in which diabetes is also one of them. So,
yes,
do you think this is going to help to detect diabetes in early stages?
yes, sir. But then we need to work more, I think, because lot of funding is going into communicable diseases. But then, if you see the
Okay.
number of deaths that is happening because of communicable diseases like diabetes, hypertension, and ultimately cardiovascular mortality. So, my
Okay.
personal view is we need to spend more on this condition for me.
More of finance has to be diverted towards this condition.
Yes, of course.
And the last query from my side,
Exactly.
implicit diabetes means obesity is one of the factor for diabetes. And do you think that lipolysis will reduce the cases of diabetes mellitus? Because diabetes itself, as you shown in your slide, one of the factor in 8 factor, that is lipolysis, right? If lipolysis increases diabetes, then is this going to persist in obese patient once they have been subjected to lipolysis?
Sir, a natural weight, this lipolysis is different. What happens in pathophysiology? What happens is
Okay.
because we don't have glucose supply to peripheral tissues, the lipolysis happens to generate energy, and
Ah,
this lipolysis will lead to a lot of oxidative free radicals and oxidative stress in body. These free radicals again lead to inflammation, sir, inflammatory process, and again beta cell destruction happens. So this is a little different. And in obese patients, if we can reduce the peripheral fat, that will definitely reduce the insulin resistance in those patients, and we can reduce the insulin resistance, and requirement of medicine goes down, sir. That is my personal experience. So nowadays we not only treat the sugars, we also look upon the weight of the patient, BMI, and we would like to keep the patient at good BMI to give good results.
thank you, Dr. Rupam. Thank you so much, and so nice of you for making all things very clear. Now, I'll request uh, Vinod, Shruti, Olay, Hina Dikshit, Sundar, and Priyanka to please come on the screen. You can turn on your cameras so that at least we see your faces, that you are there and you were there, right? If you can come one by one. Otherwise, we'll close the session over here. Rupam, if you have to pass on any message to all the... Okay, hello, how Samuel, how are you?
I'm fine, doctor. Thank you for the opportunity. I'm in Ghana, and it's good morning here.
Turn on your video, please. Turn on your camera.
Okay. This is Samuel. I'm speaking from Ghana, and I want to thank doctor for the opportunity. I've actually been enlightened on this topic, and I want to say I'm most grateful. But I had a child, those that I work with, and one was diagnosed of diabetes, and I was shocked, and I was asking myself at this age, why diabetes? So with the education I've had, but I want to know why is type 1 so rampant or is among children, and how can we deal with that among children, the type 1? Thank you so much for the opportunity. I'm most grateful.
Okay. Thank you very much. Rupam to take call.
Yeah. So, should I answer his question?
Yeah. Please
So
answer.
we have already shown how type 1 diabetes happens. In young children, what happens is they have genetic predisposition. First thing. Second thing, there are a lot of genes like HLA, DQ. I have already shown DR4, DR3, which are responsible for type 1 diabetes mellitus. apart from that, we also have idiopathic type 1 diabetes mellitus. Idiopathic means we don't know why it is happening. So these are the two things. And on top of that, the risk factors are like viral infections in early phase of life, like mumps, rubella, Coxsackie virus, a lot of other viruses. I mean, viral infection that happens in our childhood can lead to production of autoantibodies in body, which eventually kills the beta cells. So this is very unfortunate because of one mumps infection. Why should someone's beta cell be destructed? But this is how it is, and that's why type 1 diabetes is found more in children, and it is very aggressive in children. But then, having said that, it also may happen in older population, like after 20s, and most of those cases are misdiagnosed as type 2 diabetes mellitus. So yeah, that is what my answer would be. Samuel.
Okay, I think Samuel will. Yes, Samuel, is this all right? Any other query?
Yes. 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 Thank you so much. But I wanted. This is a simple question. Can type 1 lead to type 2? Thank you.
No, Samuel, type 1 and type 2 are totally different aspects.
Yeah, different.
But very interesting question. A type 2 diabetic patient can become a type 1 in due course of time. I mean, not theoretically, not by definition, but type 1 means see, it is said that you become type 2 when 50% of your beta cells are already gone at diagnosis. So slowly what happens is the beta cell will degrade, and that's how patients know after 10 years of diabetic, patients no longer they respond to oral medication, and we need to give insulin 2-3 shots because their beta cell has degraded. So now there will be one point when there will be zero beta cells in those patients. So I mean, not by definition, but in those cases we can say that that patient become like a type 1 diabetic. But then there will be always insulin resistance aspect with type 2 diabetes. It is associated, which is not seen in type 1 diabetic patients.
Thank you so much. I'm most grateful.
Yes.
Thank you. Anybody else who would like to have any query or question? If no, then we conclude this session here. Thank you, Rupam. Thank you very much for this nice.
Thank you so much. And I mean, your questions were. I mean, it was awesome. Your questions are totally. It gives insight. I mean, it makes us think about those specific points. Thank you, sir.
It's my pleasure. I also wanted to learn. I'm in learning phase, so that was one chapter which you have taught, and so nice of you. Thank you. We'll keep on the meeting on the webinars. Thank you very much. So here we conclude the session, right? Bye. Have a nice time. Bye bye. Jaimin bhai, webinar. Thank you very much.